out to be more of today's emphasis. Nevertheless, as we go through medications today, we're going to be emphasizing treatment principles and approaches. Last week we talked about comprehensive treatment and how a treatment plan, if it is comprehensive, includes these multiple components to be most helpful for students. And how a combination of therapies is what is shown to be most efficacious, including the combination of medication plus psychotherapy, which research has shown is more efficacious than either one alone for the treatment of depression and anxiety. Nevertheless, especially with younger children, we want to usually start out with psychotherapy or talking therapy, while there's been a lot of standard of care that involves both, especially for older youth and with more severe problems. But whenever medication is prescribed, there really needs to be psychosocial interventions as well. And this is posited by the American Academy of Child and Adolescent Psychiatry and supported by a number of other sources, including the TAD study, Treatment for Adolescents with Depression, and how the combination of fluoxetine and SSRI antidepressant plus cognitive behavioral therapy was more efficacious than either one alone during the acute and continuation phases of treatment. And last week the point was made that the same study has been cited as one that doesn't show a difference because later on, longer term, a year and a half later, the cognitive behavioral therapy alone can prove as efficacious as the combination. But it's during the acute and continuation phases, that is, during the first several months, the combination is more efficacious. And that's so important considering the increased risk for suicide and other problems during that time. So are there any questions that are lingering from last week before we move on to talk about selections and integration?
No.
No.
Okay. Well, today's main objective is to distinguish 6 classes of psychotropic medications and select those that are most efficacious for student depression and anxiety treatment. So, as implied, the clinical psychopharmacology offers these medication classes that have therapeutic benefit for student depression and anxiety. And we're going to select those that are most efficacious. Insofar as the intention here is not to use all these different kinds of medication classes for student depression and anxiety, but to talk about which ones are efficacious and what other ones sometimes might be used, and what are some of the other ones that some students have been already taken before they've been assessed as having depression and or anxiety. Okay? Well, let's take a moment and talk about where we may be going with this and further orienting this to be most useful for school nurses and for nutritionists, okay, and for technical support. That is to understand how these medications might fit into overall needs of a student, going back to that notion of comprehensive treatment planning. Just like as a psychiatrist, I'm often concerned about what are youth eating, okay, who are presenting with depression and anxiety. How is their appetite in their eating, okay? How much that can contribute to how they're feeling, and vice versa, okay? So why don't we embark on this journey? But I'm also thinking, Stephanie and Bert, as we embark on this journey, I am going to tailor this to how students may bring up some of these matters to a school nurse and want to hear about the concerns that you as school nurses have. Well, the SSRI antidepressants are probably the most popular and perhaps the most efficacious for depression and anxiety. And what's really great about them is that they are so much more effective with so much less risk and problems than the older medications, and that they are effective for both anxiety and depression. These are probably the most popular medications of their kind that you've heard of. Nowadays in the media, there's so much about Zoloft, which is sertraline. Prozac has been in the media a lot since it came on the market in the later 80s, also known as fluoxetine. Lexapro, which is escitalopram, is similar to citalopram, known as Celexa. Lexapro is a more purified form, if you will. Okay. Paxil is paroxetine, Luvox is luvoxamine. These are all SSRI antidepressants. They increase the serotonin in the central nervous system by blocking its reuptake and therefore making it more available to do its thing. It doesn't make more serotonin, and the medication is not serotonin itself. It's mainly used for treatment of depression and anxiety, and it's really become the first choice recommendation for depression associated with substantial anxiety, including coexisting anxiety disorder. So what that means to say that with some students, they have anxiety that comes along with their depression and it's part of their depression. With other youth, they have as much depression and anxiety going on at the same time, and they're really co-occurring problems. Yes, they're interrelated. The point being they're both syndromal, if you will. Okay, they both can be diagnoses. There are some other uses for SSRIs, including for bulimia nervosa and for premenstrual dysphoric disorder and for impulsivity. There are a number of youth who are very impulsive and they have other kinds of clinical conditions during which the addition of some SSRI antidepressant medicine has actually helped them with their impulsive behaviors. Of note, with the red asterisk, only 2 of these medicines are actually FDA approved for treatment in youth. And I think last week there was quite a bit of explanation about off-label prescribing, how that's justified, and how that's really become the standard of care in child and adolescent psychiatry. The next class of these antidepressants are the SSNRIs, selective serotonin norepinephrine reuptake inhibitors. They're also effective for depression and coexisting anxiety. Major agents include venlafaxine, which is Effexor, and a long-acting form of that, which you probably have seen in advertisements referred to as Prestique. Very helpful for depression with associated anxiety. In rare instances, sustained hypertension has been reported, which is a concern. Another medicine in this group is duloxetine, known as Cymbalta, that's being prescribed more often these days for youth. And it's really helpful for those youth who have a lot of physical discomfort and even pain associated with their depression. There's also Remeron, known as Remeron, generic name mirtazapine, that is being prescribed more often to youth. So those are the real common classes, the SSRIs and the SSNRIs. Known at times as an atypical antidepressant is Bupropion, which has very little serotonin activity. It's much more active on norepinephrine, followed by dopamine. It also works by blocking the reuptake of the neurotransmitter. Serotonin is here in parentheses because if we were researchers, we'd be really concerned about significant serotonin activity. But for clinical circumstances and applications, the serotonin activity is not significant. It's primarily norepinephrine followed by dopamine. This causes the medication to be very helpful for those who have so-called melancholic features of depression that are characterized by low energy and motivation, sometimes called high inertia. It takes a lot of energy to get up, often in the morning, to get up and get going and stay going. So inertia from physics, object once in motion stays in motion, but getting there is where the work needs to be done. Little positive reactivity, doesn't show much facial expression or reaction to events. Concentration impairment, due to the dopamine activity, it really increases concentration and therefore is an excellent antidepressant for those who have coexisting ADHD. And there have been some studies that have shown that bupropion has actually been clinically effective for concentration impairment as part of ADHD. Okay? It tends to be really useful medicine for those who have associated disruptive and risk-taking behaviors, often referred to as novelty-seeking behaviors, for those who have coexisting overweight and obesity. Okay? In part because it doesn't cause the weight gain that you see in the SSRIs. All right? It also tends to suppress appetite a bit and promote some weight loss. And for those individuals who have low anxiety, which going along with these other features tends to make bupropion good medication. Now, a word about anxiety with bupropion. While anxiety is a known side effect of bupropion, it doesn't mean that those who have anxiety are going to get worse anxiety. And the way I think of it is, for those who have mild to moderate anxiety that is clearly part of their depression, it can actually improve with the depression treatment using bupropion. But for those who have a lot of anxiety, more akin to a coexisting anxiety disorder, bupropion is unlikely going to help anxiety in that clinical situation. Now, there are other antidepressants that really precede in their age. They precede those that we've been talking about, dating back to the 70s even. Tricyclic antidepressants, or TCAs, were in use a great deal throughout the 80s and into the 90s. They're still sometimes used, okay? But generally not prescribed as often because they have more undesirable effects. Trazodone, known as Deseril, was a very useful antidepressant in adults as an alternative to the tricyclics for those who couldn't take the tricyclics because they had a heart contraindication, such as an arrhythmia that would make tricyclics dangerous. Trazodone tended to be a very good medicine. Also works via serotonin. Effective for depression at very high doses. However, it had a very sedating side effect. Even at low doses, youth have been able to sleep very well by taking low doses of Trazodone, and therefore it's become a very commonly prescribed medication, again in low doses, to help with sleep in youth. What that means to us is we might try Benadryl to help a youth sleep, and if Benadryl doesn't work, an equal amount of Trazodone might. Moving on to another class of other antidepressants, MAOIs, the monoamine oxidase inhibitors, used to be used, especially in more serious depression, sometimes still used in treatment refractory depression, but generally have a lot greater risk and undesirable effects, so they're not used very much at all anymore. Now, there are some augmentation techniques that can be used for treating depression. Use of thyroid hormone or L-thyroxine has been useful, especially for those who have hypothyroidism, very mild hypothyroidism, subclinical hypothyroidism, where there's an abnormality in one of the thyroid tests but not in the others, and there aren't any hypothyroid symptoms. It's also been helpful as an add-on to augment even when there isn't hypothyroidism. Then there's some strategies that can be used, augmentation strategies that are serotonergic in nature, that can actually work very well along with an SSRI or an SSNRI. And that would include buspirone, known as Buspar for anxiety. That can augment the action of the other agent. Trazodone at low dose to help with sleep, and it helps with augmentation. And tryptophan, which is a precursor to serotonin synthesis, can help with augmentation. It can also help with sleep. Interestingly, in these techniques, there are different mechanisms to increase serotonin activity than that found with the SSRI antidepressants or the SSNRI antidepressants. And therefore, the combination of those two can be very effective. Lastly, another augmentation agent is a form of folate, L-methylfolate, which easily crosses the blood-brain barrier to get into the central nervous system. That can be really helpful because there are a number of individuals who don't get their dietary folate into their brains, basically, because of their genetics. They don't have the means in their transport systems to move folate from the body into the brain. But L-methylfolate will get into the brain despite that. By the way, Deplin is marketed as a pharmaceutical agent made by a pharmaceutical company. It's very expensive, and it can be very helpful for those who don't get enough folate into their brains. Well, now that we've considered agents that are used in the treatment of depression and anxiety in youth, especially those that we more commonly will see in school-based health centers and in schools, which psychotropic medications are used for more severe depression and other mood disorders? Although we may not prescribe these in school-based health centers, and we may not see many students come to the school nurse who are taking these medicines, it is good to know about them and their indications for when circumstances arrive when we do see students who take mood stabilizers, for example. That would include lithium preparations, such as lithium carbonate, or lithobid. Anticonvulsants, such as Depakote, other valproic acid preparations, carbamazepine, which is Tegretol, oxcarbazepine, which is a derivative of carbamazepine known as Trileptal, and lamotrigine, known as Lamictal. All have been used as mood stabilizers. There are some others as well, such as topiramate, which is Topamax. These shows less efficacy as a mood stabilizer. Again, being anticonvulsant medications, all of these medicines have been effective in controlling seizures. A couple of them, lithium and lamotrigine, also have antidepressant efficacy and therefore are used as agents in the treatment of depression when there isn't bipolar illness or manic states involved. These medicines really require close clinical monitoring, and with most of them, laboratory monitoring as well. Ones that commonly need laboratory monitoring include Depakote, Tegretol, and lithium. And while I would say they all need close clinical monitoring, often these days youth may get a prescription for these medicines and not be seen back for their provider for quite some time. But considering the risk of a serious condition that includes a rash, lamotrigine needs very close clinical monitoring. Other mood stabilizers include the newer atypical antipsychotic medications that are being prescribed much more often. Now, when we talk about antipsychotic medications, there are the newer atypical antipsychotics and the older neuroleptics. I think that you will recognize the names of these medicines. I'll describe their generic names. Risperidone is Risperdal. Olanzapine is Zyprexa. Quetiapine is Seroquel. Ziprasidone is Geodone. And aripiprazole is Abilify. These medicines work by affecting the activity of serotonin and dopamine, primarily involving blockade, such as reuptake inhibition. The target behaviors to use these medicines for, in addition to psychosis, include aggression, self-injury, and lability, or mood lability. So these would be in instances where a depressed and/or anxious student has very severe forms of those problems and may have some other problems going on as well. One major concern about the prescription of these newer atypical antipsychotic medications is their propensity for weight gain and therefore the development of metabolic syndrome. Next are the older neuroleptics. Among the most famous of those are Haldol, or the generic name haloperidol, as well as Thorazine, known as chlorpromazine. These act primarily by blockade of dopamine, which gives these medicines their antipsychotic action. So here's a question for you based on what we've talked about so far. What is it about the atypical antipsychotics in their actions that permit them to be helpful for mood stabilization, even depression, in addition to psychosis?
Well, because of the serotonin and dopamine activity.
That's right. The dopamine activity, in addition to, the serotonin activity, really is what permits them to have mood action, okay? Efficacy for helping with mood problems that sets them apart, in addition to having the dopamine activity for psychotic features. And I'll say that overall, the newer atypicals have fewer side effects, especially those that infect the nervous system. However, that doesn't mean that they don't have serious side effects, because they do, including side effects affecting the nervous system, such as Parkinsonism. And that can be seen even with the newest agent, aripiprazole or Abilify. It can really be quite dramatic which causes many of us to really hesitate to prescribe these medicines unless we absolutely need to. Well, lastly, let's consider which psychotropic medications have been prescribed to students before their depression and or anxiety are identified in school-based health centers. Well, benzodiazepines are medications that have anxiolytic action. Often they're referred to as anxiolytics or anti-anxiety medicines. I think most people are familiar with medicines like Valium, Clonopin, Ativan, Librium. These are all in the same class of so-called minor tranquilizers. We really don't prescribe these as first-line treatment for anxiety anymore, but we reserve them for short-term treatment of acute severe anxiety, phobia, agitation, and or insomnia. But it's really the SSRIs followed by the SSNRIs that are preferable for the treatment of ongoing anxiety. Alpha-2 agonists. By the way, I think I may be asking Kevin to help me replace that word alpha with a cool alpha symbol that I've got to find on the computer somewhere. They block central norepinephrine action. And it's a very interesting medicine that was initially found to be helpful for hypertension. It actually lowered blood pressure, and not by changing the diameters or the amount of dilation or constriction of blood vessels to manage hypertension. It did it by actually affecting the amount of norepinephrine that's released in the brain. There are a couple different medicines that do this, Clonidine and Guanfacine. Both of them are available in the immediate release and extended release versions. They've been effective for ADHD, primarily with impulsivity followed by hyperactivity, followed by the attentional problems. They really don't help much with the attentional problems. What they really help with is impulsive behaviors and impulsive aggression for various syndromes, such as a younger child who's very depressed and aggressive and does so impulsively, not in a premeditated way. For a very disruptive youth who does things very impulsively, this kind of medicine can really help. It can also help with insomnia, and when you have the combination of insomnia plus impulsive behaviors, this class of medicines is really helpful. The Clonidine tends to be more sleepy and have more sleepy side effects and other side effects, and therefore it can be more helpful to be using at night, whereas Guanfacine, which is less sedating, is more helpful to use during the day. I tend to like Guanfacine better. I find that it has a longer duration of action, less side effects overall. Well, psychostimulants such as methylphenidate or Ritalin, other methylphenidate preparations, and the amphetamines are very well known as stimulants, psychostimulants, used primarily for ADHD. And it's the action on dopamine and norepinephrine systems that appear to be the main mechanisms involved for these medications. However, they're not fully understood. And in fact, if you want to hear in more detail, I can describe to you, having gone back and reviewed the ways that I have I and my colleagues have found the mechanisms of action for these medications described over the last 15 years, and it's not only changed over time, but it's varied from one source to another, with definitely all agreeing that these are dopamine agonists. They work through dopamine action, but how they do that and to what, if any, degree of norepinephrine action is involved really varies. But I could say that the majority of information describes both dopamine and norepinephrine activity. There are more and more preparations of methylphenidate all the time, and most of them are long-acting medications that can be taken in the morning only. I would say Concerta is probably the most popular one currently. Amphetamine is in preparations known as dexedrine, in mixed amphetamine salts, which is Adderall, and in Vyvanse, which is called a prodrug. It's actually similar to amphetamines before a pass through the liver where they're metabolized. There is a caveat, though, that these medicines can actually worsen depression and anxiety, and therefore there are a number of youth who have been on these medicines who've had more difficulties taking them, developing more side effects, getting more diagnoses, and therefore more medications. Okay? But often ADHD in and of itself has been misdiagnosed, and there are a number of youth who have underlying depression and or anxiety. They're misdiagnosed as having ADHD, they're prescribed these medicines, and unfortunately it just worsens their depression and anxiety. There's some other medications that are frequently prescribed for students, such as atomoxetine, and some others that can be helpful in ways that haven't yet been tried, such as over-the-counter diphenhydramine or Benadryl. Atomoxetine or Strattera is actually an SNRI. It's not an SSNRI, but it's an SNRI, a selective norepinephrine reuptake inhibitor. It tends to have efficacy in the so-called ADD, that is the inattentive type of ADHD, more so than with the combined type that includes impulsivity, hyperactivity, and distractibility, or the combination of the first two, impulsivity and hyperactivity. It also has potential benefit for the treatment of depression and anxiety because, technically speaking, it is an antidepressant medicine. And it has been shown in some clinical studies to help with anxiety. I would like to mention something to you to make a connection to the mechanism of action of psychostimulants that I mentioned previously. We know that some agents, such as atomoxetine or Strattera, work primarily on norepinephrine, and they are helpful with ADHD, but not to the extent of the psychostimulants. And bupropion has also had a mechanism of action involving these neurotransmitters, still not as effective as psychostimulants. And it really is thought to have to do with the degree to which these agents impact the dopamine and norepinephrine systems in the brain. Now, going back to something I said earlier about diphenhydramine or Benadryl, it is commonly used for insomnia in youth, and that's as an alternative to a sleeper medication, if you will. There are a number of sleeping medications out there. They're much more often prescribed for adults than for youth. Some of the medications listed in the benzodiazepine class that are used for anxiety have also been prescribed for sleep. Okay? We tend not to do that very much for youth. We tend to try more milder medications such as diphenhydramine or Benadryl. Some people have used a derivative of this medicine that has a brand name of Dramamine, which is called dimenhydrinate, and that is actually a different salt of the same medicine. These can be helpful for anxiety as well as insomnia. They're sometimes used as an as-needed basis for anxiety. It's interesting that we call them, we call the side effect a drying of the mucosal membranes when we use them for sleep, but when we use them for allergies, we say that they have a sleepy side effect. These are the action of the medications, and we utilize them how we can. Also, it's been found that these are agents, the diphenhydramine preparations, are very safe prescriptions or recommendations when there are very young children who have out-of-control behavior, because the medicine can really help simmer them down, again, in a very safe way. And I'd have to say that as a psychiatrist, I have found this to be a very good solution in clinical settings when I've been referred a 3-year-old with a report that they are out of control at daycare and at home, and a little bit of diphenhydramine has really helped them, and it can be available over the counter and including in liquid formulations. Well, some dosing guidelines for student psychotropic medication prescription includes always start low and go slow. Start low and gradually increase the dose. This is really important. Why? There needs to be some adjustment phase. I think everybody agrees that children need to get used to taking something and see how their body is going to react. So, keeping with the trend that if side effects are going to happen, they're going to happen sooner in the prescription of a medication while the benefits take longer. For most all of these medicines we've been talking about today, with the exception of the psychostimulants and the alpha-2 agonists, starting low, seeing if they have side effects. A lower dose can allow those side effects to be less intense while the body is adjusting, the person is adjusting, and then the dose can go on from there to be raised up as high as doses taken by adults, because youth have such rapid metabolisms given their body size, they can actually take adult-sized doses eventually. Well, how would this apply to the school setting? I'm thinking, Stephanie, Bert, a student comes in to see the school nurse because they've been referred to by their teacher, because the student is really tired in class. They've been prescribed an antidepressant medication at a standard dose. Say Zoloft or sertraline has a standard dose of 50 milligrams. They were just started at 50 milligrams and they got tired and were sleepy in class. What might be a consideration for you in what you would do about this?
Well, I always call the parent and let them know what's going on. That's my number one thing to do.
Right on. And it may be a situation like we talked about last week, where you hadn't been notified that the student is taking a medication. Maybe you know they've been started on a medicine, you don't know what it is, or you don't even know they're taking a medicine. And it's through calling the parent that you find out, Juan was just started on a new antidepressant. I'd have to look at the bottle for what it's called. The bottle reads sertraline, and you ask what the dose is just out of curiosity, and the parent says, take one 50 milligram tablet or a half of 100. So they're taking 50 milligrams. What do you think of then?
Well, then we have to encourage them to call the doctor
Right on. I agree with that. And, and then at that point, would you consider it part of your role to share with the parent that, maybe a lower dose might be more agreeable with the student initially?
Yes, it's not the first thing I say, but as you say, you want to be careful how you instruct people on medication.
Well, indeed, and I understand that your role would not be to instruct about how the medicine is taken, but would you see it as part of your scope of your roles that you would suggest that perhaps an adjustment in the dose might help the student?
Yes, that's I would. But again, we have to talk to the doctor.
Well, and I think, as you said earlier, the parent would be encouraged to talk to the doctor.
Mm-hmm.
I imagine you, Bert and Stephanie, saying something such as, if the doctor has any questions, would like to know what we noticed about Juan here at school today, we would welcome his call, his or her call.
Mm-hmm.
I'm also thinking of a scenario that goes something like this, where the issues we were just talking about would come up, where the parent might react rather strongly and say, I was afraid that was going to happen. I didn't want this medicine prescribed to my son in the first place. Gosh darn it.
Yeah.
And then it might be really helpful to the parent and be reassuring to say, and tell me if this would fit for you, and Stephanie likewise. Well, sometimes an adjustment of the medicine is all that is needed. That the medicine might be really helpful to your son. However, it'd be really worthwhile talking to the doctor about whether this is the best dose for him.
That sounds good.
Because then I think you're not instructing the parent about what to do with the dose. You're not instructing the doctor about that. And you're really encouraging the communication and talking about options.
Right.
I was wondering if Stephanie, are you still there?
Yeah, I've been the one talking. I'm wondering about
I'm sorry.
Bert.
I'm sorry. I thought that was Bert. I'm so embarrassed.
That's okay.
I appreciate your contributions.
Dr. Rifkin, this is Bert. Can you hear me?
Yes.
Hello?
Yes,
Okay.
I hear you.
Yes. Okay. I've been talking and nobody can hear me. I have had that happen where they fall asleep in class, and I usually call the parent and when they just start a new medication. And I tell them, that this is not unusual. They do need to call their doctor. And the doctor has to start somewhere, and he can titrate it down. He will find the right adjustment for the student, but they have to keep an open line of communication with that doctor, and to please feel free and call him with their concerns.
Well, I really, I agree, and I think that's an excellent application of the points that we've been talking about. So I thank you for sharing your comments, your thoughts, and your concerns about that. I think that Stephanie and Bert, you're both on the same page. And again, Stephanie and Bert, sorry for misidentifying you there.
That's okay. I don't think you could hear me for a while.
I couldn't, and it's because I knew on some level that you were out there talking, Bert, that I got confused and thought you were Stephanie. I swear. I could just tell.
Two great minds, one great thought.
You bet. I'll take whatever I can out of that. So I think what we're talking about really fits with an integrated approach to psychopharmacotherapy that we encourage in school-based health centers here in Envision, New Mexico, where we have quality improvement initiatives. Because for any prescriber or provider in a school-based health center, as well as in a community clinic where these medicines could be prescribed, we really don't want the provider to be the Lone Ranger. Integrators are welcome to talk about how people can work together to provide the comprehensive care needed to promote the treatment that the student needs. Basically, the principles involve integrating the care that involves involving a treatment team, that there's continuous collaboration both while students are being served and when the team has a chance to all meet together. And what we do in our quality improvement initiative is that we really encouraged a formalizing of the team conferencing and implementing procedures for prescribing and monitoring that really fit with what we were talking about last week. And Ellie, that basically encouraged monitoring enough, monitoring often enough, making sure that medications are adjusted and that there be information available for how that adjustment is done. Because we really can't begin collaborating early enough, as that was our twins at about 17 months, and of course they continue to collaborate at 12 and a half, just like they did back then. We could only hope. But in our collaborative care overview, what we try to do is integrate the care within the school-based health center. And if we had a school-based health center where we were doing this integration within the school where Bert and Stephanie are, that we would be collaborating with both of you at our respective sites, and that we would coordinate the care with the providers out in the nearby community. You know, I would welcome Bert and Stephanie if you ever want to discuss these topics or others further as they come up in your schools. I would be glad to hear from you. We have telepsychiatry consultation available a few hours every week. I'm available to do that. And while it's been traditionally oriented toward school-based health center and other pediatric providers, there have been a number of school nurses who have called requesting consultation over the years, and I'd be glad to hear from you.
Thank you.
Yeah, definitely. And the instructions are there. And also on our website, if you go to envision.nm.org and click on telehealth and go to telepsychiatry on the left side of the page, we'll be there. And there's a way to schedule something and we can talk.
Okay.
Thank you.
Thank
I
you,
mentioned
Dr. Rikfin.
earlier a policy statement by the American Academy in Child and Adolescent Psychiatry. We also have practice parameters that we follow in order to provide a standard of efficacious and safe care for children. I've also included some other references, textbooks, for example, that are still considered relatively recent, but that's about to change next month. So if you wish to receive your CME or CEU, I think that there's a good chance you're going to get that, as Kevin and I know you're there.
Mm-hmm.
And I thank you for joining us today, and I definitely want to acknowledge Kevin's help. Clancy is here behind the scenes as well, and that's who you schedule your telepsychiatry consultation with. So thank you very much for joining us this afternoon.
Thank you so much, Dr. Rikfin.
Bye.
Bye. Bye, Stephanie.
Bye, Bruce.
Bye.
Bye.